Hello, everyone, and welcome to today's webinar on overcoming headwinds and harnessing tailwinds, achieving financial sustainability with IDR under the No Surprises Act. My name is Jacob Emerson. I'm with Becker's Healthcare. And on behalf of all of us here at Becker's, thank you so much for taking the time to be with us today. Now, over the next hour, we'll be exploring how provider groups and a dedicated IDR company like HaloMD are transforming provider-payer negotiations and driving sustainable, fair reimbursement through the process of independent resolution under the No Surprises Act. Before we begin, I'm going to walk through a few quick housekeeping instructions for our audience. We'll begin today's webinar with a panel presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Now, today's session is being recorded and will be available after the event. You can use the same link you used to log into today's recording to access the webinar at any time. And if at any time you don't see your slides moving or you're having trouble with the audio, try refreshing your browser first. You can also submit any technical questions into the Q&A box. We're here to help at any time. So with that, I'd like to introduce HaloMD and our panel of speakers joining us today. HaloMD is one of the top submitting entities in the federal independent dispute resolution process under the No Surprises Act, according to CMS. The organization reports an average success rate of over 90% in payment determinations. On average, their IDR outcomes result in reimbursements more than 8 times the qualifying payment amount. And to date, they've secured over $1 billion in annual awards through the IDR process. So with that, I'd like to introduce our speakers today, have them go around and talk a little bit more about their healthcare career backgrounds and give an overview of their current roles. So, Paula, I'll come to you first.
Thank you so much for that introduction. So I'm Ala LaRoque, president and founder of HaloMD. And with us here, we have Megan Rausch, who's our chief operating officer, as well as Dr. Vo, who is the CEO and chairman of Nutex Health, and John Bates, chief financial officer of Nutex Health. That's the panel for today. Happy to be here. And without further ado, we'll roll right in. And as mentioned, what makes us kind of the experts in the space is the fact that we focus on IDR submissions and IDR process on both NSA level and state level across the country. Today's discussion will focus strictly on the federal No Surprises Act. We'll probably do another webinar later on down the road for multiple state level prohibitions and how to conduct arbitration on state level. This is federal NSA presentation only. And I think we'll go right into tailwinds and headwinds. Do you have a question for us?
I do. I was wondering, Ala, if you could go over, you've obviously outlined these headwinds for us. What do you believe is the biggest financial impact on providers today, and how can it be addressed?
I think that besides financial impact, I want to make sure that the audience understands that No Surprises Act to date has accomplished exactly what it was set out to do. It was set out to protect patients from surprise bills from out-of-network providers. That has been fixed. Patients have, 30 million patients, as a matter of fact, have avoided receiving surprise medical bill, which is a huge victory. Also, their cost share, their out-of-pocket outlay has been capitated down to in-network rates, which are significantly less than historical out-of-network cost share and deductibles. So patients are protected. This has been an amazing advocacy act for that reason. It also is providing sustainability access to patient care due to the fact that provider groups who do participate in IDR are seeing significant success in this process of finally being able to receive fair and reasonable reimbursement. And that literally is sustaining healthcare and allowing these providers to avoid filing bankruptcy, going out of business, having to reduce their staff. So access to patient care is actually being sustained by this process. From a financial standpoint for providers, I would say that there are a lot of tailwinds in the process, especially compared to 22 and 23. If you look at just an average engagement of the market, you've got about 178% increase in payment determinations, which obviously are telling us, and that's just a quarterly stat or biannual stat, that sees that the market is definitely recognizing the opportunity of what independent dispute resolution brings, and more provider groups are engaging in this process. Interesting fact, and we'll have a little bit more information about this later, but it's important to know that your IDR offers and award determinations are not limited to bill charges. We'll actually show you statutory language that supports that, CMS's response that supports that as well. So that's an opportunity for providers not only to engage in the process and receive fair and reasonable payment, but also potentially to recoup any and all expenses they're having to incur through this process. In addition to that, I would say that QPA is a major factor here, and traditionally, and through various reports from CMS, we have all seen that arbitrators or independent third-party decision makers are awarding providers significant percentage over initial QPA or initial payment that's being paid to them by the health plans. So fair and reasonable payment now lies in the hands of independent third-party legal minds. The shift of control is here. Providers are able to engage in a process that provides balance and eliminates their inability to sustain their business. Increasing success rate, you can see based on the most recent report from CMS, providers are winning 86% of the time, and that's a 2% increase from last time CMS reported, which was 84% of the time. In addition to this, we're seeing that IDREs on the administrative side, which are independent dispute resolution entities, are providing more data. There's more transparency. There's more engagement. There's significantly, improved process of how IDREs interact with both parties, payers and providers in this process, which is creating incredible efficiencies in the space. And of course, what we've seen being reported recently is that once provider groups are engaged in IDR, the process is seeing 99% retention rate, which means that once providers have successfully been able to kind of implement the process, figure out all their, how to overcome the roadblocks and the obstacles and the challenges, they're staying in the process and seeing this as a really viable solution to their financial sustainability. 99% of them are staying in the process. To a little bit further, and this is kind of speaks to your market adoption. In 2022, there were 200,000 disputes that were submitted and awarded. In 2025, we anticipate that 4 million disputes will be submitted into IDR process under No Surprises Act. So obviously trajectory from 22 to 23, 3 times continues to grow, doubled itself in 24. We anticipate that will be more than double in 2025. Again, this is a projected number that we're seeing based on the current submissions to CMS. If you look at QPA, an increase in outcomes over the initial qualified payment amount, which is the median in-network rate based on 2019 with an inflation rate added to it. That's what QPA stands for. And usually a lot of health plans have adopted QPA as their initial allowed amount or initial payment. Through the process of IDR, and this is factual statistical data, various specialties participating in this space or in the process, and we just outlined the top 4. there are probably about 15 other specialties that are currently actively participating in the process. But you can see that emergency medicine is seeing a 257% increase over QPA. Hospitalists are seeing over 331% over QPA, 585% increase in radiology over the initial allowed amount, and about 207% in anesthesia. And I will let Megan kind of cover the headwinds and opportunities for improvement in the process of IDR. Again, the process is still building, it is still progressing, it is still improving. And what we're going to share with you today, headwinds that are in front of us, really are not so much statutory or regulatory for the most part. They're more administrative. So we have a lot of suggestions and solutions, which we're constantly verbalizing to IDREs, to CMS, even to payers, in how to improve the process to make it more scalable. So Megan, if you would please cover kind of the current headwinds and opportunities for improvement.
Would love to. Thank you, Alla. So as Alla referenced, there's been a lot of great things in this process that have happened, but there is still room for improvement. The overall item is the lack of standardization amongst the different IDREs. They all are applying different logic to batching rules, to cooling. So a lot of messiness as it relates to that. So one of the key things will be for CMS to come out and standardize all of the reporting templates. That goes into potentially creating a portal that is overall mandated by CMS and controlled by CMS, so everybody has complete visibility into that process. Part of that also goes into a lot of the redundant information requests that you're seeing. If you are active in this process, you'll submit a lot of documentation, and then the IDREs will often overlook that documentation and you have to supply it again. So a lot of extra work is being created on the back end of that. The other big thing is the refund mechanism issue. So a lot of the IDREs are struggling to where to send those refunds out to. So mandating all ACH refunds would be key in order for the providers and the health plans to be able to get their money back on the back end, since this is a kind of pay to play and people are having to put out a lot of cash to make this a meaningful process. The eligibility identification challenges are becoming more and more. The IDREs are struggling to understand what is eligible, what is not eligible. And this is not all of the IDREs. There are some IDREs in the process that do it really great. And Alla will actually go over a whole slide that talks about how to choose an IDRE and what you should be looking at, because a lot of us look at win ratio, and that win ratio is only one portion of what the things are that you should be considering. And then the biggest thing and the final thing on this slide that I want to kind of anchor to, and Alla will have additional slides as well, is the delays in implementing the final rules. So final rules were put out last year. However, CMS has not officially announced them.
Thank you, Megan. And we'll spend a little bit more time on kind of educating best practices on exactly how the deck is going. Somebody's pressing the deck. Sorry about that. There you go. We'll spend some additional time on providing best practices on how exactly to engage an IDRE in order to receive your refunds timely and to the right provider, to the right account, and how that whole process should be shifted and changed. So we've seen some tremendous success in that lane and would love to share our learnings. So moving on, again, more headwinds if you just kind of put them all in one bucket. Frequent post-eligibility challenges is that a lot of times, even though the objection period by statute is only 3 days, we're seeing that health plans quite often will object to an award determination significantly post, in delay time. They'll do it after award determinations have been issued. They'll do it after IDR has already received the offer and the payment has been made. So the fact that CMS is somewhat flexible on that rule currently is definitely causing a problem, because by statutory language, once award determination is issued, it is final, It is not, you cannot reopen it, you cannot amend it, you cannot recoup against it, refund against it. It stands. So the challenges that we've seen with CMS being somewhat flexible with certain objections, not all objections, is causing concern, and we're definitely working very closely with them to understand how to overcome that non-compliance, because 3 days at the beginning of the process should be sufficient for an objection to be issued for both parties, to be honest. Transparency and data sharing obviously has seen some gaps. Currently, CMS portal does not allow for APIs. It does not allow for any type of reporting or interactive data exchange. That is an issue. We're hoping. Next each question. Okay. We're hoping that that will be solved in the near future. This is an interesting fact to it that CMS has reported that IDR process is one of the very few, if not the only government program that is actually profitable. So CMS does have enough resources to be able to deploy the fees that are being charged, not just to staffing CMS and their complaint department to kind of higher numbers for coverage and for efficiencies, but also to deploy some of the funding towards technologies very much needed to be able to create a better flow of IDR. So again, if you get an opportunity to speak to CMS or to IDREs or really anybody who will listen, the portal for CMS and development of that portal with data exchange is absolutely a must. Payment delays, we'll have some slides on that as well. Obviously, traditionally, most of the providers are reporting that about 70% of their disputes, they're not saying they're not paid, they're just saying they're not paid timely. And we do have some additional slides on this to kind of give you best practices on how to interact with payers once you receive an award determination, to make sure that the payer is aware of the fact that there is essentially a quote unquote judgment against them, and then that payment does need to be made within 30 calendar days. We have seen significant success in how we conduct that workflow, if you will. So we'll definitely share our insights during a little bit later during this presentation. You do have also obviously ground air ambulance. Its unaddressed specialty is still waiting for the rules to come out in order for that specialty to be able to participate in IDR process. For specialties like radiology, the small dollar amount disputes are still having to pay the same amount per dispute, which is fairly burdensome, as the larger procedures or higher amounts of claims. And that does seem to be incredibly unfair when the cost to participate in independent dispute resolution to be able to get your fair and reasonable payment exceeds the opportunity. There's something very broken with the system. And having limited batching rules also does not help, the kind of the smaller claim value specialties to participate and effectively work their claims or their disputes through the IDR process. Of course, CMS currently controls resubmission links whenever if IDRE ever makes a mistake, which is called an administrative mistake. IDREs, in our opinion, should absolutely have access to reopen the dispute on their own. Right now, they're having to submit a request and basically state that they basically made an administrative error, and at times they have to wait for 3, 4, sometimes 6 months until CMS actually responds back with a resubmission link. That process, if IDRE has issued basically, a rule or a verdict that they made a mistake, administrative mistake, they should be able to reopen that dispute timely and reprocess it. And of course, lack of accountability. If you look at the process, both health plans and providers, initiating parties, not initiating parties, have been held to higher standards. If either party does not submit a payment right on time to IDRE, they get a default judgment determination, award determination. If they do not submit an offer, they get a default award determination. If you fail to submit any type of information to IDRE within the 4 to 5 required business days, you also get, and sometimes a closure of that dispute, or sometimes the IDRE will make a decision based on the other party's objection, and a lot of times it's incorrect. So both parties participating in the process, initiating party being most of the time the provider, not initiating party being the payer, are being held to a higher standard. IDREs have not been to date. They lapse times a lot of times on when they're supposed to award. IDRE fees, according to the market, are not being refunded timely or to the correct provider groups. So there has to be equality in that space where IDREs are held to the higher standard, just like the rest of the participating parties. What we would recommend, I would say that we talked about centralized CMS portal already. Make sure that you, as an organization, if you currently participate in IDR process, contact every single IDRE. There are 11 right now that are participating, 2 are on pause, and insist on enrolling your accounts into ACH refund. It is an enrollment. You do have to communicate with them. Some of them require verbal authentication and authorization with their bank. However, once you do this, it literally eliminates any type of potential loss of IDRE fee refund checks that are going to box 33, to your RCM vendor, to some logbox, and nobody in the payment posting knows exactly what to do with that check. Or you may be receiving checks that don't even belong to your provider group. They belong to somebody else. Yes, that has happened. So make sure that you contact your every single IDRE and ask for ACH enrollment. That's going to be pivotal to your success in this lane. Improving transparency and reporting, we've kind of talked about this as well. IDREs, at least 6 IDREs currently, are able to provide both health plans and providers a report, and a lot of them can custom make this report with data fields that you require, whether it's additional financial metrics that you'd like to see, or deadlines, or just statusing. They're able to provide those reports to you on weekly basis, monthly basis. We normally get them on weekly basis from the IDREs. We recommend that. It allows you to kind of catch anything that falls out a lot quicker. But again, you can set up any type of cadence you'd like. But those reports are available from 6 IDREs. I would highly recommend that you contact them and build your own reports so you can therefore drive efficiencies, communicate effectively. And if there's ever a distressed case, you can kind of triage that dispute very, very quickly before it actually defaults. So that's a really important pivot. In empowering operational teams, this process is very much a partnership between RCM vendors and IDR agents and provider groups that do it themselves in this space. So training RCM payment posting teams exactly how to post IDR payments, how to post refunds that are coming in from IDREs. And so therefore there's accurate reporting of what has not been paid, so you can kind of effectively start implementing workflow to collect that money from the health plans, is really, really critical. I can tell you sitting here is that I would say 95% of the time when we have to contact a health plan, they're getting really bad rep in this space, I guess, claiming that they're not paying their IDR fees timely. We are not seeing that 95% of the time. If there is a failure, usually they're lacking some type of data. They're either lacking an EOB, they're lacking that award letter, they're lacking some type of factual number or qualifier or quantifier that they need to be able to process that claim. It is your job or your IDR vendor's job to provide that additional information to the payer. And again, I think the process will improve as time goes on. But if you provide that, we see those payments coming in routinely and they're coming in quickly. So it is a very burdensome process, having to contact, hundreds of thousands of different payers or I should say, on different claims. However, the process works once that initial contact is initiated. So highly recommend that you engage at least in some type of engagement with payers and provide them with award letters, provide them with additional information that is needed. Megan, do you have anything else to add to this in terms of, I know you're very familiar with EOBs and kind of how they're being posted or how they're being reprocessed by the payers. Do you want to talk about that just a little bit?
Absolutely. In terms of the remittance advices that you guys are getting as a result of the IDR process, you'll see that oftentimes they are recouping the initial and then posting and repaying everything. So you'll want to just net those out so you can track what your initial payment was versus the payment as a result of IDRE. Also, don't rely on the CARC codes and the remark codes because they're not accurate all of the time. You really need to track internally so that you can determine what your success rate is in terms of getting the payments in the door.
And Megan, based off of all your tactical recommendations, which of all of these would have the greatest one-day impact for the providers on the call if implemented?
Oh, that's a tough question. I mean, I think everything goes back to centralized CMS portal. If that could be implemented, and from setting up APIs, if available, to interactive reporting, to having providers being able to perhaps make a payment, open negotiations in the portal, that will eliminate a lot of inefficiencies in this process for both parties, frankly, for health plans as well as for providers. Being able to pay IDRA fee, not having to go through their payment link, and each of them have developed their own kind of payment structure, having kind of a centralized portal where you can make a payment, click on a drop down, choose your IDRE, or better yet, enter your dispute number, and then the IDRE that's been selected would drop in with it. I can design this on the fly. And being able to pay this via ACH and get refunds and get refund reports, that'll be absolutely instrumental. It will propel this process and eliminate a lot of financial burden, eliminate a lot of lag in time to successful determinations. So I think that would be my number one if I was to highlight one. Megan, do you have a different opinion on what would be your kind of, since you're an ops, number one on this list?
I don't. I think the transparency around a portal would be key for all parties involved, both the health plan and the providers going into this.
So this is my favorite slide. We've presented this slide numerous times at numerous conventions. Happy to share this. We've been fortunate enough to build technology that actually does this in real time. But even if you don't have a technology solution for this, how you select your IDRE is critical. There's a lot of misconception about exactly how IDRE is selected. So it's important to know that if there's not an agreement after the first kind of challenge by the non-initiating party, you are going to end up in a random pool. That's factual. A lot of people think, they have to play a game up till midnight and they're going to get their IDRE. That's not factual. If you do not agree, if the health plan does not agree with your selection, by midnight, you're going into a random pool of selections. So what's interesting about IDRE selection is we actually measure success of IDRE not by win ratio, even though that would seem to be the most natural measurement, right? That's actually probably our number 5 on the list. We look to see of how are they conducting themselves and how are they processing these awards, how timely they are, how quickly do they respond, how quickly do they provide IDRE fee payments back. They have 30 business days to refund you back. That's your cash flow as a provider. And frankly, that's also your cash flow as a health plan. So having those refunds hit your bank account within 5 business days instead of 30 allows you to process next dispute and the next dispute that much more efficiently. So IDREs who are issuing disputes, payments or refunds a lot earlier do get kind of in front of the line. Predictability, you know, there's a lot to be said about kind of bipolar behavior of different IDREs, and especially on the front end when it comes to eligibility or some of the administrative duties that they have to perform. So it's really important that, you know, you choose an IDRE that nails the process of eligibility, because otherwise you're going to have to overcome closures, having to provide additional information. Once the dispute is closed, it has to go to CMS. It sits there for 4 to 6 months before it can be reopened, even though it should have never been closed in the first place. So choosing the right IDRE where you're actually marking how they're, you know, how effective they are in that process is critically important. Batching rules. There's still a few IDREs out there that are not adopting the kind of the flexible batching rules, if you will. They're still not allowing providers to even submit on a claim level. We do not use that IDRE. We do not select them because they make the process incredibly more expensive and very, very burdensome. Then, of course, your win ratio, naturally, if you have a high win ratio with certain IDRE, it's one of the components. But again, I want to emphasize very strongly, it's not everything. If you hit on all cylinders, if that IDRE hits on all cylinders for the other factors, you are going to get a successful result. Timeline also is critically important. So by statute, as you all know, and this is also another clarification, there's misconception out there that the award determination is due. And again, I want to highlight that this is a misconception. The award determination is due after you submit your payment or your offer. That is not correct. The IDRE by statute actually has to issue an award determination 30 days from the date that they're selected. So from the day that you get an email that says, this is the IDRE that has been selected, they have 30 business days to award that determination. Most of them in the past have failed that timeline. I can tell you that 4 right now routinely provide award determinations prior to 30 business days even expiring. So those become your preferred IDREs because they have been effectively able to staff up to create a process that allows for award determinations to be awarded that much quicker. Megan, do you want to go? Actually, I'll go through this one. I'll let you grab the next one. Give me 1 sec. Best practices. This is something that we also, I would say, discovered. And literally, a lot of times when you read FAQs, you read the statute, you have to read it 2 to 3 times to really understand what was it intended to say? What did it intend to do? So what's interesting is when you read the statutory language, and this is really helpful for a lot of health plans, we've been providing quite a bit of education because there was a lot of confusion when, you know, we essentially first came out with this discovery of a statute. Your offer amount, and this applies to both parties, initiating, non-initiating party, is not limited to bill charges. The statute clearly says that each party will provide an offer. It does not say an offer that's capitated to bill charges, that's not to exceed bill charges, that's not to be higher than bill charges. As a matter of fact, bill charge is a prohibited factor in the process of IDR. So providers and health plans, frankly, can absolutely submit offers that exceed bill charges, and that has become a method of recoupment for initiating parties of their expenses that they're having to put into this process, such as non-refundable CMS fees. Perhaps you have an agent like Halo MD who's doing your IDR. Perhaps you have you had to, you know, borrow on your line of credit and you have interest rate that you're paying on to be able to even fund your IDRE fees. All of those expenses and costs, just like in regular arbitration, should be refundable back to you if you prevail. So with that being said, the offer amount can include your costs for participating and being pushed into the IDR process. So we've got the legal basis there. That's the statutory language that allows this. We have confirmed this with CMS numerous times. As a matter of fact, for full disclosure, Initially, when we implemented this workflow, and again, this is not 100% of the time, this is for qualified eligible disputes that qualify based on that algorithmic formula, if you will. CMS had to educate health plans because they did not know how to post award determinations, how to pay those, because traditionally they've never exceeded bill charges. That was their method of capitation. So now we've seen significant adoption by most payers. There's still a few that are confused. And again, education will continue, where they understand that the award determination as issued needs to be paid regardless whether it is below bill charges or above bill charges or at bill charges. So I'm sure I'll have questions on this, so I'll move on to the next one and then happy to answer any additional questions after we finish.
Wonderful.
We have 5 minutes to get through this. Go ahead, please.
Thanks, Hala. So I want to go over to the New Text team because they've seen a great deal of success through HaloMD IDR. Can you all walk us through how that partnership with HaloMD was operationalized and then scaled?
Yeah, hi, Jacob. Hi, everyone. Thank you, Becker. Thank you, HaloMD, for inviting us to this call. So yeah, as you can see, we run Nutex Health. We run 24 hospitals in 11 states. We've been operational since about 2010 or so, but we've only been public since about 2022. And obviously the NSA started in 2022. And that was basically probably the biggest hurdle that we faced when we became public, when our revenue dropped by about 35%. And as you can see, with the 35% drop in revenue, went straight to our bottom line, profitability-wise. And so as an operator of a 24/7 series of hospitals nationwide, we are sort of like the safety net for the community. And by the way, even though our hospitals are very, very small, they serve a major need for the community. And most of the patients that we service are very satisfied. And if you take a look at pretty much any of our sort of like social media reviews, you can see that our Google reviews are just very, very high, which is very unusual in healthcare. And so as such, we would like to get fair and equitable payment for our services, since we're open 24/7, open at 2 a.m., open on Saturdays, Sundays, Thanksgiving, New Year, so on and so forth. So that's basically the basis of what we do, what we need to do. And so since the payment decreased in 2022, we've been fighting very hard to get back to where we were. And we've known about arbitration for, I would say, since the beginning of 22, but before it was very inefficient. It was still very expensive. Ever since arbitration became much more streamlined and more affordable, beginning in late 2023 and early 2024, we decided to jump head in and start to arbitrate. And by the way, arbitration is a bit of a last line for us. Because we would rather get fair and equitable payment upfront and not have to arbitrate. Unfortunately, that is not the case with payments. And so arbitration was sort of like our strategy to basically be on an even keel. So with that, I'll pass the torch over to John Bates, our CFO, to explain a little bit more about the process and what he's seeing since we started this arbitration process. John?
Yeah. Thanks, Tom. Thanks, Jacob. Thanks, Ala, and the team. So as Tom described, we started this process really full bore in the latter part of the second quarter, really beginning of the third quarter of 2024. And as we indicated earlier, there is a relatively large barrier to entry from a cost perspective. It is somewhat, not somewhat significant to get into the arbitration world, but we saw the results that Halo had been able to provide and the industry is showing. And so we started that in the third quarter. It did take us a good 4 to 5 months to see the process kind of work through the engine between our strong revenue cycle team and the HaloMD impact. And as a result, in the fourth quarter, we started to see a lot of that positive fruits of the effort that went into it, and started to see the successes coming in and the determinations, as Ala indicated earlier, and then the process of trying to get paid. And while there has been, a significant amount of success there, the delays from the payer side has been somewhat relevant. We do have to watch that as we go. But the consistent pattern that we've seen since that process started back in the third quarter, rolling all the way through into the fourth quarter, and then even into the first part of 2025, we're very excited about the opportunity to be able to go through this process, because we really feel like at the end of the day, just getting a fair and equitable payment is all we're really trying to accomplish. And prior to this point, we don't feel like that was happening, and it wasn't happening very much at all. So that's kind of the process. I think we talked about how around 60 to 70% of our visits that we see on a daily basis, we're able to go through this process. So it's a decent percentage of our business, and we're going to continue to do this until we can get to the point of making sure that we're getting that fair and equitable payment down the road. Going into, and you talk about the fourth quarter, you see the impact there. I mean, obviously that 80 to 90% win rate has been pretty consistent. We've seen that as well. And as a business, period over period, year over year, we definitely had a pretty high increase in overall revenue year over year, but really just putting us in line with what we believe we should have been getting paid from an equitable kind of a fairness standpoint. So efficiency wise, we've really improved working with the Halo team. There's a handoff process and we have to work real closely together. And so we've really improved on that as we've done this over the last 6 to 7 months. It takes some time to do that and refine that process. And certainly, our ability to continue to grow as we open up facilities and be able to add, the existing and plus our newer facilities into this process is a big part of what we're doing. And then with the ultimate goal, I mean, as a business, we're a publicly traded company. Our shareholders are the most important piece of what we work towards, is just making sure we have that financial stability long term. And we believe that right now, using this process is one of our best chances to keep that running as steadily as we've seen it through the end of the third quarter and fourth quarter and finishing out the year of 24 and into 25. So excited to have this partnership and see where we go from here.
One thing that I'd like to point out, if you can see that 270% increase in revenue year over year. So that is revenue that we feel that should have been paid from the beginning. So in other words, even though the increase in year over year seems high, that is what we felt should have been paid from day one. And so arbitration allows us to do that, to get back and try to get a fair payment from the beginning.
Absolutely. And I think, Dr. Vo, to add to that, I think there's actually an article that came out in Becker's today that speaks about compression and out-of-network reimbursement, where between 2018 to 22, out-of-network providers have seen close to 40% compression in reimbursement on their initial payments. So this process allows for, equitable payment, for fair and reasonable payment. And again, the fairness of the process really lies in the fact that there is an independent third party that is making this decision, where it's no longer being made by a single party, whether it's payer or the health plan. It is a legal mind who is reviewing, all the data, all the needed, factors, if you will, because we do have to submit an answer to factors in the process. So does the health plan, and they're deciding that this is what's fair and equitable. So, it's definitely shifted in decision making, but it is going to provide sustainability to companies like Nutex and others in being able to grow and provide access to patient care. Megan, if you don't mind covering, go ahead, Dr. Vo.
No, I was going to say, no, you're right. It is a formal legal process that I think is allowing us to achieve these numbers, and that's fair and equitable. And once again, we just want to be fair and equitable. We don't need to collect any more than what anyone else collects. So as long as we get that, then we're happy. And thanks to arbitration, that's been the case so far as we see it.
Thank you, Dr. Vo.
Thank you very much. Go ahead, Megan.
We always approach all of our conversations as an education platform. So if you're currently doing IDR, thinking about doing IDR internally or partnering with somebody like Halo, these are a lot of the areas in which you could potentially go wrong in the process. So first and foremost, verification of benefits on the front end. Olive referenced earlier, we're talking a lot about No Surprises Act today specifically, but there are 20 bifurcated states that have a balanced billing prohibition on the state level that applies to a subset of the insurance plan. So being able to do verification of benefits accurately on the front end and understanding what cases apply through the No Surprises Act versus which cases apply through the state level balanced billing prohibition is key to your success right off the bat. Next is missing filing payment or deadlines. All of the processes, whether on state or NSA, all very timely. You have 3 days to do something, 4 days to do something, 10 days to submit a position statement, 30 business days versus calendar days on some of the items. So it's really important to know and track all of those deadlines, because if you miss it even by a day, then you have now lost that case's eligibility potentially. That goes into the failing to timely object to the disputes. The payers are oftentimes putting out objections in there. So you really want to make sure that you're following those objections. You either align and agree and say, yes, I messed up. I missed that open negotiation deadline by 1 day, or you're objecting to their objection and showing proof on that side. I'll already talked a lot about the IDRE process, so I'll skip over that one. Cooling is a whole conversation in and of itself. If you're in the process, you know the cooling rules, but failing to administer those cooling rules are very important, because it can kick disputes out and cause a bunch of administrative burdensome down the line. Knowing and tracking all of your supporting documentation. You need to be able to have the verification of benefits down to the open negotiation proof. A lot of this anchors to what Olive references. This is a legal argument you're building, so documentation at every aspect is key to the success in front of the arbitrator. Already referenced the state requirements earlier. I won't go too in depth into those, but knowing all of those state requirements and those 20 different processes, one for each of the bifurcated states. And then the final kind of two are the batching rules. Each of the IDREs that Olive referenced earlier follow different batching guidelines. And because CMS has not put it out there yet that this is the official batching rules, and this is what all the IDREs, knowing all of those batching rules and which IDREs want which types of batch is going to be crucial to success. And then the final item is that open negotiation. So a lot of times the payers can change their email address. They want, you to send some claims to MultiPlan or Zealous or a third party. So being able to know and track all of those internally will be key, because if you do send it to the wrong place, you've lost your opportunity there.
Thank you, Megan. And I know we want to leave, we have a lot of questions that are coming in, so we want to leave some room for questions. I'm going to go to kind of what I feel our most impactful slide. And this is, we always like to provide value to those who are, billing out of network, considering participating in IDR process, or if you're already doing this process, we're always discovering kind of, reading FAQs from CMS is critically important. Like I said, rereading the statute. Most recently, we just discovered a new rule that CMS put out. And I'll go straight to that because of the time constraint. We have a lot of things on future proposed rules. We can go through that. How to apply for extenuating circumstances. Again, this will probably be our next webinar. But I do want to tell you about this. So most recent FAQ that came out from CMS, there's a question buried in there where CMS has clarified and issued new guidance that, frankly, even IDRE that we were just at a conference with did not know that this happened. So we kind of, shed the light on this, is that if you did not receive the required disclosures from the health plan on your historical EOBs, starting from the beginning of NSA process, which was January 1st of 2022, you now have an opportunity to submit all of those disputes, open negotiations, and then disputes into the IDR process. There's no time limitation to this that has been identified or given by CMS. It's open-ended. So I want to very, very quickly, literally within 2 minutes, and this is probably the most impactful kind of, opportunity, if you will, that you'll probably take away from this webinar. This is critically important. Again, if you have any questions, feel free to contact us via email. You can reach out to us on HubSpot. I mean, there's numerous ways you can get in touch with us so we can explain to you a little bit better how to initiate this process. But if I was to just summarize it very quickly, payers are required by statute to provide you with an email address where you need to send them their open negotiation. They're required to provide you with a disclosure of a plan type. And then they're also required to tell you whether that claim qualifies for IDR, state, or NSA. If you did not see that disclosure on your EOB, of course, it would not be on your 835, 837 form, but on your EOB or, whatever you're getting from your clearinghouse on the remark codes, you now have an opportunity to resubmit all those disputes into the process starting from January 1st of 2022. We have actively engaged in just kind of looking to see what our providers, our customers have, and there are hundreds and thousands of these type of EOBs were back in 2022, even 23, and believe it or not, even some in 24, health plans were not disclosing all the required, and it has to be all the required disclosure elements on their EOBs. So if you don't have those, you can now submit them. So I'll leave it there because there are a lot of questions, but this is a great rule. It's FAQ that just came out, and we can actually direct you right to the question so you can read it yourself. But an opportunity for those who have not participated to perhaps look to see if you were not able to participate because you simply did not have that disclosure. And I'll take question number 1 since we're running out of time.
Wonderful. Thanks, Alla. And like you said, we're getting a lot of audience interest in our presentation today and a lot of questions coming in. So let's get right to our Q&A portion. How many organizations are actually getting paid after winning the IDR process?
Market is reporting, so there's a difference between getting paid period or getting paid timely or getting paid late, right? So there are 3 buckets. When it comes to getting paid timely, the industry is reporting, this is market, this is not just Halo data. Halo data excluded from that, I should say. They're saying about 60% are not getting paid timely. They're getting paid late. There's also about 25 to 30%, according to the industry, that is not getting paid, period. Now, I say that with a bit of a grain of salt because a lot of times RCM vendors who actually engage in the process of, IDR payment recovery, they'll contact the payer and say, we did not get paid for this specific claim. The payer then provides them with proof that they did pay it. Then they discover that it was misposted. So it's very, very hard to flush out what is actually getting paid and not posted properly, what is being sent to the wrong, logbox, and what is truly not getting paid. And again, in situations when it's a true non-payment, 95% of the time, it is not because of will or intent not to pay. And I know I'm speaking very favorably of health plans, and there's a lot of doubt in the provider community about the process. But from personal experience, from what we see, they just need to get additional information, and you will get your payment. So hopefully that answers your question. We're successful in our pipes, if you will, with our clients, where we're seeing closer to 80 to 85% of those payments being paid timely, and then we do have to chase down the 15 by providing additional information. Hopefully that answers the question.
And Alla, we're seeing interest in how refunds can be issued to parties representing a provider, such as attorneys or vendors, because this, of course, is a very cumbersome process.
Absolutely. Believe it or not, IDREs would actually prefer that method of refund. So if you were to ask an IDRE, I want to enroll in ACH and I have 10 different NPIs that we bill from, and we want 10 different accounts set up through ACH, they will do it. I mean, we've enrolled hundreds, but they prefer to have one kind of aggregate account if they can. So it is a matter of contacting them as an agent, and depending how you have that financial vehicle structured with your providers, but you can absolutely say anybody that gets submitted under this domain, the refunds need to come to this account, this ACH, and then you can kind of effectively issue your workflow on how you get that money back to the provider if the provider is issuing those payments. By statute, it states that the refund will be issued back to the prevailing party. So, but being a prevailing party, again, you can set up an ACH account, obviously with authorization of your client, and get those refunds directly to you. And that's a preferred method for IDREs.
And in a situation where there's an IDR award, but the payer refuses to pay, what are your suggested ways to receive payment other than filing a lawsuit?
Absolutely. So as you go through the process of IDR, most payers have dedicated NSA or just, IDR departments. Identifying representatives who are actually responsible for, payments for IDR specifically, instead of sending it to your broad box that says, name of a payer at NSA.com, you're sending it to Monica Brown at, this payer's address where, with a copy to the main inbox, but you at least identified a representative who is going to be very proactive, who's going to be responsive. And we've been able to kind of build a Rolodex almost with most payers for the actual designated team members on their end who can effectively, triage these, claims that were not paid or awards that were not paid timely and figure out how to get a payment to the provider. Another thing that CMS constantly suggests, IDRE suggests that filing complaint with CMS, an actual complaint. Frankly, we're hoping that's going to be an effective vehicle in the future. CMS is incredibly backlogged. So can you file a complaint? Yes, but frankly, we believe in resolving it directly with the payer directly, and it does happen instead of, kind of putting it on CMS's radar and waiting for 6 months for them to respond. So that would be my solution. Attorneys from health plans, we do communicate with a couple of attorneys who will get a spreadsheet from us if there's, a few disputes that simply did not see payment. They're also very effective in helping us kind of understand where to go with our distressed AR and who can help getting those payments actually issued.
Elaborate on the 3 days timeline to raise an objection in terms of when it can be raised and the process to do so.
Sure. So from the time that you select your IDRE, when the IDRE is resolving their conflict or they're actually issuing attestation that they do not have conflict, within those 3 days, the payer or any party participant can issue an objection, but that objection is limited to those 3 days. And it's statutory too. I don't know if I can drop it in the chat, but if you want to contact us, we'll give you the statute that actually spells out the objection period and how to effectively enforce it.
And for our audience who we can't get to questions, there are a lot of them. You can see the QR code to contact Halo MD up on the presentation right now. But IDR offer amount that's not limited to billed charges. What has been your success rate, and have you noticed IDREs offering favorable determination more than billed charges?
100%. So I'm not saying 100% success rate, but yes, they are awarding those disputes and award determination. You have to remember one thing about IDR. This is baseball style arbitration. There are 2 offers on the table, one from the health plan, one from the provider group. And this is really decision making of what's most fair and reasonable. It is very reasonable for a provider who submitted a dispute through initial phase of open negotiations. So this is essentially initial mediation phase, who have attempted to resolve this dispute through, non-arbitration methodology, right? Vehicle, that's mediation, that's open negotiation. 30 business days, that's a long time to attempt to resolve this dispute. And if the health plan is non-reactive, non-participating, or brings in an offer that is really significantly below what's fair and reasonable, then essentially that health plan has pushed this provider into the arbitration process because they have no other vehicle of resolution besides this process. When somebody is pushed into arbitration, it is natural to think that their costs, if they prevail, should be reimbursed to them, because at the end of the day, the offer amount that they're going for should be their actual payment, and all the expenses incurred during the process of arbitration should be reimbursed. So yes, we're seeing success. Yes, it is at the same 90+ win ratio. And yes, we have been doing this type of, again, on eligible disputes. I want to make sure that somebody doesn't take an understanding that this is applied to every single dispute. This is based on eligibility and validating disputes if we can actually effectively add the cost to that offer amount. But we're seeing the same success rate, whether we would do it without the costs of arbitration or with. It's above 90%.
Wonderful. Well, unfortunately, that is all the time that we have for today. So I want to thank Alla, Megan, Thomas, and John for taking part in an excellent discussion, and Halo MD for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. You can also scan the QR code to contact Halo MD to learn more. As Alla mentioned, you can contact them directly via email and HubSpot. On behalf of all of us here at Becker's Healthcare, thank you so much for taking the time to be with us. We hope that you have a wonderful rest of your afternoon. Goodbye.